So it's a real privilege for me to introduce, welcome my friend and colleague, Dr. IMAD HUSSAIN, who's been a great addition to our heart failure group. He completed his internship and residency at Emory, followed by his cardiology training at Mayo. He did his advanced heart failure training at University of Washington in Seattle, and has just been doing a superb job. So research focus in heart failure with preserved EF, which he promises not to be disappointing following heart failure with reduced ejection fraction. and really he's positioned nicely to give us a primer, if you will, on detecting and treating heart failure with preserved EF. Ahmad?
Morning and welcome again to the Heart Failure Summit. So I'm going to take the next 20 to 25 minutes, hopefully a little over, because it's a broad topic. I get 1/3 of the time, you know. So anyway, so I want to start off. I'm going to start off with a case presentation that delineates this problem, and then we'll move on from there. This is a 65-year-old female, progressive dyspnea on exertion and chest pain, more chronic NYHA class 3 symptoms, has had previous hospitalizations for heart failure, has a past medical history of hypertension, type 2 diabetes, CKD stage 3, chronic atrial fibrillation. She's on a rate control strategy and anticoagulation with Coumadin. Physical examination shows a blood pressure of 136/84, BMI is 31, neck veins are elevated, and there's minimal trace peripheral edema. The NT-proBNP is elevated at 627, creatinine's 1.7, which is obviously abnormal. These are her cardiac medications. She's on warfarin, Lasix 40 milligrams daily. She takes 5 milligrams of lisinopril, Toprol XL, and statins, as well as glipizide for diabetes. This is her EKG. In the interest of time, this shows chronic atrial fibrillation. There's a right bundle branch block. There's also a left axis deviation. So this is Mayo format, so bear with me. Basically, in this scenario, this is the LVs on this side, all right, for just references, because it is opposite to what convention is. So normal LV size, EF is about 55%. LA volume index is 72, which is severely elevated. Deceleration time on the mitral inflow is 140 milliseconds, which is short. E prime is 0.04 meters per second, and an EE prime ratio is 32. Looking at the tricuspid valve envelope, you see an estimated RVSP of 34 millimeters of mercury. The TAPSE, which is a measure of RV systolic function, is reduced at 14 millimeters. And this is the envelope, as you can see, it's probably not a complete envelope, and it's likely underestimating RVSP. So she proceeded with a cardiopulmonary exercise test. Peak VO2 was reduced at 10.8 mLs per kilogram per minute, which is 49% predicted. RER of 1.23, what it's telling you is it was an adequate effort. VE-VCO2 is a measure of ventilatory inefficiency and was abnormal at 39. Peak heart rate was 153 beats per minute, so she's 65 years of age. This is likely an adequate heart rate response to exercise. Her peak systolic blood pressure, although, dropped with exercise. This is her coronary angiogram. I'll let it play for a second for you guys to take a look at it and make your formulate your own interpretation as well. So she actually proceeded with the right heart catheterization. What you see here is a mean RA pressure of 15. The wedge is elevated at 23. Look at the mean pulmonary artery pressure. It's severely elevated, 50 millimeters of mercury. The transpulmonary gradient is the difference between the mean PA pressure and the pulmonary capillary wedge pressure. So it's 27 millimeters of mercury, significantly elevated. Cardiac output is low at 3.9. Pulmonary vascular resistance, and I've given you a range, actually less than 1.5 is considered normal, but less than 3 is considered okay. The PVR is elevated at 6.9 Wood units. LVEDP was also 25 millimeters of mercury, correlating with the wedge. So this patient was given nitric oxide challenge in the cath lab, and what you see here is interesting. So what happened is her wedge actually went up from 23 to 36 millimeters of mercury, and her mean PA pressure only came down by 5 points. But as a result of this, you look, the transpulmonary gradient went from 27, which is significantly elevated, to only 9, which is almost normal. Cardiac output actually dropped, and the PVR now is less than 3 Wood units with nitric oxide challenge. This is the actual waveform. As you can see here, this was baseline. With the nitric oxide challenge, you can see these really gigantic, prominent V waves hitting 60 millimeters of mercury. The echocardiogram did not show any significant mitral regurgitation. So, okay, so this is the audience response. So the question I have for you is, what is the diagnosis in this patient? Is this idiopathic pulmonary arterial hypertension? Is this heart failure preserved EF with group 2 pulmonary hypertension? Is this symptomatic atrial fibrillation? Is this just that she's old, obese, and deconditioned, or cardiac syndrome X? So go ahead and vote. What did I do here? Should I press this? Okay, so I guess because it's the topic. Okay, but you guys are at least listening. All right. So okay, this is a little tougher question then. And some people already voted, but how would you treat this patient? Would you give this patient a beta blocker? Would you continue an ACE inhibitor? Would you implant a cardio-MEMS device? Would you treat the patient with the PDE5 inhibitor like sildenafil? Or would you try for a rhythm-controlled strategy in this patient? Okay, so the polls are coming. Sorry, there's dynamic change. So no one thinks rhythm control is actually even an option here. And then there's kind of equipoise between ACE inhibitor and implanting a cardio-MEMS, and some people think PDE5 inhibitor and then beta blocker. So it's a good topic to talk about. What are the treatment options, if any, for heart failure with preserved ejection fraction? So I want to start off by telling you two key things in heart failure preserved ejection fraction. It is a disease of the elderly, and it is a disease that is characterized by comorbidities. Those two things are the hallmarks of heart failure with preserved ejection fraction. What you see here is the cardiovascular health study. It was a community study of elderly patients over the age of 65 years. And what you see here is that the prevalence of heart failure overall was 8.8%, but 80% of those patients with heart failure had an EF that was over 45%. So the predominant form of heart failure in the elderly is heart failure with preserved ejection fraction. Now, as I told you, heart failure preserved ejection fraction, or HFpEF, is a disease of comorbidities. So they have all sorts of comorbidities: diabetes, hypertension, anemia, you name it, COPD, sleep apnea. And on average, in terms of non-cardiovascular comorbidities, patients with HFpEF have at least 4 comorbid conditions. And that I'm talking about only non-cardiovascular comorbidities. If you take into account cardiovascular comorbidities like coronary artery disease, hypertension, and atrial fibrillation, that is even more comorbidity burden on top of what I've already explained to you. So it's a disease characterized by comorbidities. The reason why I'm stressing on this is the next slide. Actually, let me just go on to this one. It's actually the slide after this, but atrial fibrillation is a very common thing in heart failure preserved ejection fraction. So much so that 2/3 of patients with HFpEF at some point either have prior or will develop atrial fibrillation. And why is that important? The reason why that's important is atrial fibrillation is independently associated with functional capacity and mortality in HFpEF, adjusting for all comorbidities. So because of this comorbidity theory, let me explain one of the pathophysiological mechanisms that we think is important playing a role in HFpEF. So you have all these comorbidities. We think that that causes a state of chronic low-grade systemic inflammation with these inflammatory markers. They result in inflammatory cells coming into the myocardium and via the TGF-beta pathway causing downstream fibrosis. That's one mechanism. The other thing this chronic inflammatory state does is it causes microvascular endothelial inflammation. So this endothelial inflammation is not just in the heart. It's in the vasculature, it's in the skeletal muscles, it's everywhere because it's a systemic process. So this creates reactive oxygen species that scavenge nitric oxide. And why is nitric oxide pathway important? So nitric oxide pathway, think of that as an anti-fibrotic pathway. All beneficial cardiovascular effects A lot of it is due to the nitric oxide pathway. So these reactive oxygen species, when they scavenge nitric oxide, you lose this favorable signaling, and as a result will have hypertrophy and and fibrosis. So, so that leads to the what happens. What are the structural abnormalities that you see in heart failure, preserved ejection fraction? So as a result of that chronic inflammatory state and increased fibrosis, which occurs both at the level of the extracellular matrix as well as the cardiomyocyte stiffness itself increases, and the net result of which is impaired LV filling. The same thing is happening in the vasculature, so you have increased vascular stiffness, decreased vascular distensibility. That leads to a concept, very important concept, it can be a lecture on its own, called ventricular vascular uncoupling. And this is another mechanism that increases afterload on the heart. Now, we have moved away from calling this diastolic heart failure or diastolic dysfunction because HFpEF is not just diastolic dysfunction. As you can see, it has to do with ventricular vascular uncoupling due to increased vascular stiffness. You also have chronotropic incompetence in HFpEF, and now we know that you also have a subtle systolic dysfunction. Even though the EF is normal, if you were to do LV strain by echo on these patients, it's abnormal, suggesting that there's subclinical or subtle systolic dysfunction, and definitely when they exercise, they fail to augment their cardiac output like normal people would. So there is more to HFpEF than just diastolic dysfunction, and that's why now we coin the term as heart failure with preserved ejection fraction. So how prevalent is this condition? Well, this condition is very prevalent. Whether you look at community or referral cohort, it's about half of the burden of heart failure with preserved ejection fraction. The prevalence has increased over time, as you can see from 1980s to 2002, likely due to increase in comorbidity burden. And the mortality in HFpEF versus HFrEF is about the same based on community studies, although clinical trials, I think they typically, the inclusion criteria, they have less comorbidities, and hence in the clinical trial population, the outcomes are somewhat better. So this is a simple diagnostic algorithm for patients who are suspicious of HFpEF. So understand HFpEF does not equal diastolic dysfunction, so you should have symptoms that are consistent with heart failure. And if you have an EF of greater than 50%, move on to the echocardiogram. And if your echocardiogram shows a tissue Doppler E prime velocity of 8 centimeters per second or less, that is abnormal. If it's like 12, then you got to think outside the box. Think of other things that can have preserved ejection fraction and can cause heart failure symptoms like constriction or non-cardiac dyspnea. Now, if you do have this, if you meet that criteria, go and look at the EE prime, which is assessment of non-invasive way of assessing filling pressures. If that's greater than 13, you have your diagnosis. If not, then you can look at some of the other diastolic parameters that are available to you by echo. You can look at NT-proBNP or BNP. If they're elevated, then that would rule in a diagnosis. That's kind of a simple working algorithm. When do you do right heart catheterization? My patient had a right heart catheterization, but when do you have to do it? So most of the times you don't have to do this. So if you do an echo on a patient that you're suspicious of heart failure and they meet these criteria, but you have a PA systolic pressure that's 60 millimeters of mercury or more, that is a little out of proportion to what you could explain by just because of elevated filling pressures. That is a patient you want to do a right heart cath primarily to rule out a mixed pulmonary hypertension picture, patients who have elevated pulmonary vascular resistance that could be treated differently. All right, so I just wanted to give you one point about look for other non-HEF causes of people with normal ejection fraction. Hypertrophic cardiomyopathy and amyloid are the big ones there. Pulmonary arterial hypertension with RV failure can present with volume overload and shortness of breath and can mimic sometimes heart failure preserved ejection fraction. High output heart failure can do it. And then one just take home point from this is that when you do an echo and you see LVH and your wall thickness is greater than 15 millimeters, think something else. Think infiltrative cardiomyopathy, hypertrophic cardiomyopathy. Think outside the box. Very rarely does hypertensive heart disease give you thickness of the heart muscle that exceeds 15 millimeters. So now I'm going to go into some of the treatment options that I presented to you as the second question and see what we have in the literature out there. So basically this slide is just showing you an overall meta-analysis of patients who were on neurohormonal modulation. So whether it's ARBs, ACE inhibitors, beta blockers, or digoxin, none of them have ever shown a benefit in patients with heart failure preserved ejection fraction. So I'm going to go into some of these trials. So this is a meta-analysis of RAAS antagonism in HFpEF. And as you can see, in 8,021 patients in the total population, there is no difference in heart failure hospitalization or mortality in patients who are treated with RAAS antagonism in HFpEF. And hence, these agents are not helpful. That doesn't mean you don't use them. If someone has hypertension and they need treatment and they have some other indication like diabetes or coronary artery disease, by all means, you should put them on ACE inhibitors. But for HFpEF, directly, it has shown no benefit. So what about the mineralocorticoid receptor antagonists like spironolactone? So this was studied in the TOPCAT trial. In my opinion, that was not a totally negative trial. Overall, you'll see that the hazards ratio, there was not a significant reduction in the endpoint. The endpoint was cardiovascular death, heart failure hospitalization, or resuscitated cardiac arrest. But when you substratify it, at least when you look at the primary outcome of heart failure hospitalizations, there was a significant difference. Spironolactone decreased heart failure hospitalization. And then, because this was a multi-country trial, if you go by region, in the Americas, so North America and South America, this was actually a positive trial. Whereas in Russia and Georgia, it was a negative trial. And there are reasons behind that due to time constraints I can't go into, or we can maybe discuss in the form of questions. But the point is that to take from here is that there was a regional difference in this trial, and in the Americas, it was actually a positive trial and showing benefit of spironolactone. So what about the seniors trial? So seniors trial was a beta blocker trial of nebivolol. Let me give you the rationale. So if someone has high heart rates with diastolic heart failure or heart failure preserved ejection fraction, you understand that because of the shortened diastole, they don't have adequate filling. So it makes sense that if you slow down their heart rate, they would have some benefit in terms of at least symptoms, if not any other outcomes. So this was the seniors trial. This was nebivolol, which is a beta blocker with vasodilating properties. And in patients with an ejection fraction of greater than 35%, and that's how they define it, which is a weird cutoff because the guidelines now suggest using 50%, but a lot of the clinical trials had 40 to 50%, but this one had greater than 35% as the cutoff, but it showed no benefit in terms of primary outcome. At this time, so I apologize that this is the other way around. So this is a registry. The Optimized Heart Failure Study was a large registry with patients who were discharged on beta blockers. And for obvious reasons, for patients who had HFrEF, I'm sorry, this is the opposite way around, they had a survival benefit. But patients who had heart failure, preserved ejection fraction, and were discharged on beta blocker, they had no survival benefit from if they had HFpEF. So Ivabradine was also studied recently in heart failure with preserved ejection fraction, same concept, reducing heart rate and improving LV filling and seeing if that translated. So their outcomes that they looked at was 6-minute walk test and EE prime, which is a measure of filling pressures. And as you can see, this was also a negative trial and did not show any benefit in terms of improvement in 6-minute walk distance or improvement in EE prime ratio. That means reduction in LV filling pressures. That did not occur with Ivabradine. So there was no benefit of heart lowering with Ivabradine in terms of improvement in functional capacity or diastolic dysfunction. Now this is an important slide. I want to show you this. So if you're seeing a patient in clinic who has diastolic heart failure and you look at the echo and this is what you're seeing, the restrictive filling pattern, and look at all this. This is wasted time. So this is a patient who's over beta blocked. Patients with heart failure, preserved ejection fraction, they have a very fixed stroke volume. So the way they're maintaining the cardiac output would be heart rate, right? So if you look, most of the filling is occurring in early diastole, and all this is silent. This is a patient you should back off on if they're on beta blockers. This patient's heart rate happened to be 48 beats per minute, and that would improve their symptoms. So they're actually the opposite. Too much beta blockade is not good either, as I demonstrate in Doppler waveform. So crunch for time here. Okay, so basically, I wanted first, before I discuss the RELAX trial, which was sildenafil in heart failure, understand, I talked to you about this nitric oxide pathway, and I said it has beneficial cardiovascular effects through the cyclic GMP pathway. PDE5 is an enzyme that degrades cyclic GMP. Sildenafil blocks this, thereby increasing this signaling pathway. The RELAX trial was also a negative trial, as you can see, compared to the primary endpoint in that was change in peak VO2, which is an objective measure of functional capacity. There was no change in patients who were on sildenafil versus placebo. Then next, there was a recent trial called the NEAT HFpEF trial that that looked at nitrates in heart failure with preserved ejection fraction, and they used an accelerometer to see how much they would walk and to measure activity. So it actually had the opposite effect here. Patients who were on IMDUR, were actually less active, no matter how you looked at it. Now, there is Dr. Borlaug in particular is involved in this inorganic nitrite. The concept is inorganic nitrites in the state of hypoxia, especially when you're exercising, can be degraded into active nitric oxide, and that can have a favorable effect on exercise capacity. What he showed in the cath lab is that patients who were on nitrite, when you exercise them, they had less of an increase in wedge pressure as opposed to the placebo. At least a proof of concept that this may be beneficial, but ongoing trials to see if this will pan out. But this is just a proof of concept paper that I presented to you here. Now, I might go a few minutes over. So I just want to make one observation regarding statins in heart failure with preserved ejection fraction. There are large observation studies that have shown, because as you know, statins have an anti-inflammatory effect, and because we think it's a systemic inflammatory process that is occurring in HFpEF pathophysiology, that this may be beneficial. And this was an observational study, and even at till 3 years, there was a significant difference in survival in patients who were on statins, and this was after adjusting for lipid levels, coronary artery disease, diabetes, and hypertension. However, there are no randomized controlled trials of statins in HFpEF, but there is a suggestion that maybe they may be beneficial. So I would like to just real briefly touch on a few novel things that are coming out. So the Paramount trial looked at Entresto or LC696 in patients. This was a open label study. No, it was not. It was a randomized phase 2 study that looked at BNP reduction. It did not look at clinical outcomes. Paragon Heart Failure is the new trial, which is the phase 3 study that is coming out. In my opinion, anecdotally, we have several patients with HFpEF that we've been treating with Entresto, and they have had benefit in terms of functional capacity. So this may be a positive trial in my opinion, but we'll wait for it to come out. CardioMEMS is, in the interest of time, I'm not going to go over how it's implanted, but CardioMEMS has shown, is the only intervention that has shown reduction in heart failure hospitalization minus spironolactone, which I feel in the TopCat trial did. So it was a 50% relative risk reduction with CardioMEMS in patients with heart failure with preserved ejection fraction at 6 months. And so this is definitely a thing you can do for patients who present with recurrent heart failure and get admitted with recurrent heart failure. One quick slide on a new trial. This is the LAP heart failure trial that uses this intra-atrial septal device that can be placed in the cath lab via transseptal puncture. We are going to be a new site for that very soon. We've had our site initiation visit, and early data for open label study have shown sustained improvement in NYHA class, Minnesota Living with Heart Failure questionnaire, and 6-minute walk distance at 1 year. So this is a trial that is starting as a phase 3 study, and we'll be a part of it. Exercise training is the only thing that has shown to improve functional capacity in heart failure preserved ejection fraction. And so I'm just showing changes in peak VO2. This is a meta-analysis of all exercise training out there. And if you augment that with weight loss, the effect in the change in peak VO2 is even better. So weight loss alone and diet and exercise alone are helpful, but if you do both, it's even more helpful. So this is a simple measure that can improve exercise capacity in heart failure with preserved ejection fraction. Unfortunately, like HFrEF, Medicare is not approved, this is not an approved indication for cardiac rehab. So that is one problem that we have with our patients referring them to cardiac rehab. The last thing very quickly, so these are the new updated 2017 guidelines for heart failure with preserved ejection fraction. The only class 1 recommendations are hypertension control and diuretics for the treatment of volume overload. The only new thing in the guidelines is now there's a class 2B recommendation to use aldactone based on the results of the TopCat trial, but these are patients that should have elevated BNP levels and should not have chronic renal insufficiency. And the only other new thing in the new guidelines is that now they're recommending, it's a grade 3 recommendation, class 3 recommendation to use nitrates based on the NEAT HFpEF trial, and the phosphodiesterase PDE5 inhibitors like sildenafil based on the negative RELAX trial. And I'll stop there. All right, sorry, I went over a little over. Sorry.
Imad, thanks. We gave you the most challenging topic to fit in 20, 25 minutes, and very nice overview. Very nice overview. So we do have 4 to 5 minutes for questions.
So in diastolic heart failure patients, do we focus on heart rate control or not in patients with diastolic heart failure?
So patients with diastolic heart failure, you need to focus on heart rate control. There are various benefits of that. Now, first one is coronary artery disease, comorbid condition, and HFpEF. So by controlling that, you decrease metabolic demand, you decrease the heart rate, improve LV filling time. What I demonstrated there is when you over beta block them and their heart rate's very slow, then because they have a fixed stroke volume, they need some degree of heart rate to maintain a cardiac output. So if you slow them down too much and you have this type of filling pattern on their echo, those are patients you should back off on beta blockers or whatever you're using for rate control.
So what is the optimal heart rate for?
So I can give you a range, maybe 70 to 85 beats per minute, but individualize it to the patient because we all obtain echoes. Look at their mitral inflow patterns.
Thank you.
I got a question regarding the CardioMEMS. Hypothetically, if you could implant a CardioMEMS in everyone with diastolic dysfunction, and then keep them out of the hospital, how much of a cost reduction could that possibly generate, do you think, comparable to the cost if
of heart
you just
failure
gave it
hospitalization.
for free?
So there's a cost effectiveness study on the CardioMEMS, and when well done with a good RN program or whatever an individual clinic uses as their way of monitoring and then an action plan, it is cost effective. Okay.
Excellent.
All right. Thank you very much.